So, good morning, one and all. So, as we discussed today about the conventional strategy to manage the tuberculosis, we saw the many aspects of tuberculosis, and we saw the conventional strategy how we were managing the TB till 2017. Okay, what was the regimen that we used, and how we were giving that regimen to the patient. Mm, but there was a change in 2017. Okay, the reason for that change you can understand as we discuss the first part of this chapter, like why tuberculosis is a major disease and what are the challenges in managing the tuberculosis. Like we figured out that adherence is one of the major challenges because the therapy goes for the long period of time, and we also figured out that the regimen is complex. Like some people had to take um, twice a week, some people had to take thrice a week, and then again kind of confusion, and they used to forget all those things. So forget all those things, and non-compliance used to happen. To counteract all these things, to overcome all these things, the WHO the WHO came up with this new strategy, and the government of India implemented it. So we'll come to this point after a couple of my slides. Okay, the couple of my slides are introduction in this presentation. Like what is DOTS? You know already what is DOTS. Okay, and it is recommended by WHO to detect and cure tuberculosis. And as you are seeing in the picture here, the, the patient is taking the anti-tubercular drugs in front of a trained healthcare worker. Okay, and the trained healthcare worker is watching and that the patient swallow every dose. Okay, so that there is no chances of missing the dose. And these are the general procedure that used to happen. Like they used to find using microscopy services, and the healthcare worker used to observe and record patients swallowing the full course of the correct dose of antitubercular drug for entire 8 to 6 months. And they used to then what they used to do is, as we saw in the previous presentation, that they used to they used to test the smear after 2 months, okay, to check whether the drug is effectively working or not. And once after 2 months, and again at the end of the treatment. So that at the end of the treatment, so that to figure out if they have to extend the course or not. At the end of the treatment, if the response is good, then they used to consider, okay, no need to extend. But at the end, if the response is not that good, then they used to think about it, and maybe 1 month or 2 months they used to extend depending on the case. So this was all about how it was going. Okay, and a recording and reporting system documents patient progress throughout and final outcome of treatment. These are the 5 components of the DOTS. Political and administrative committee, then good quality diagnosis primary by sputum smear microscopy, then uninterrupted supply of the good quality drugs, then 4th is DOD, and 5th is systematic monitoring and accountability. So this is the same thing what I had talked yesterday, but in terms of number, let's see in terms of stats where we stand, where the India stands. And India accounts for 1/4 of global TB burden. So you can imagine 1/4. Okay, that's 25% of the global TB burden. So that's really huge. And with the annual incidence, if you see, it's 2.2 million. Okay, annual incidence is 2.2 million, and more than 40% of Indian population is estimated to be affected with TB. Okay, this is not very old data. This is probably 1 or 2 year old data. More than 40% of Indian population. Okay, that's really concerned. That number is really concerning number. Okay, and if you if you compare around all the country, India has the highest burden of TB and multiple drug resistant TB. Okay, so that shows what's the burden of TB in India. And even we have a nice table here, and that compares the Indian burden with the global. If you see the incidence, Indian incidence 2.2 million, whereas global incidence is 9.6 million. So that's really showing us what proportion of incidence India is like India is forming out of 9.6. Similarly, prevalence if you see 2.5 million in India, 30 million all over the world. Mortality rate if you see 2.2 lakh. Okay, that's really huge. Okay, 2.2 lakh people die. Around 17 lakh people die per year. So that's mortality rate in India. That's really huge. So with the keeping with the consideration of these points, this problem that we show that this burden, okay, many new drugs are coming up. Yesterday we discussed about a little bit about betaquilin, tilaminate, and even pretomanine. Okay, so we'll see again same drug in brief here, and then we'll jump to what are the changes that happened from before 2017 and after 2017. Okay, and from 2017. So why do we need a new drug actually? Because we know that there was complexity of the regimen. Okay, first thing, so that if we can come up with a new drug which simplify that regimen, that would be great. And another reason we need to come up with a new drug is you saw most of the anti-tubercular drug have many side effects. A few of the important side effects were hepatotoxicity. So if the new regimen can overcome that, then that's a great drug. Okay, that's a great anti-TB drug. And of course, resistance. Okay? As a study also we're talking, most of the anti-tubercular drug gets resistance. Okay, that's why in that context only the topic MDR, XDR, and polyresistance, all those came in. So, and as we saw, apart from this, we also saw that there is a major challenge in managing a patient with TB and HIV because there is a post-drug interaction. Okay, and tubercular drug are generally enzyme inducer. Okay, sometimes this rifampicin kind of drug. Okay, so there is a risk of therapeutic failure for the HIV and heart therapy, and also hepatotoxicity, chances of hepatotoxicity and other side effect increases. So there is a challenge how to manage the patient who have both. So if there is a new drug which are not interacting much with each other, that will be kind of great drug. Okay, so so new TB drug we need shorter, simple, affordable. Okay, patient can afford because this is a long-term treatment. If the patient cannot afford, then it's really a problem. Then it should be more effective. As I told, it should be less toxic, less expensive. Okay, patient should tolerate, should be safe, and should not have much drug interactions. So this is what we talk. And this is a slide where we are comparing the new regimen with the old regimen. Okay, so old regimen we're telling is till 2017. New regimen is after 2017. Okay, so you can see here is Rohit here. Rohit has explained nicely about tuberculosis regimen. Is Rohit here? Rohit is not here. Okay, so what is IP? Can anyone tell? Mahesh, what is IP? Rashmi,
No, sir.
Rashmi.
Inpatient, sir. Inpatient, sir.
I'm not getting you. What you told?
Inpatient.
Impatient. Oh my God. Yesterday we discussed clearly now what is IP and CP. What is CP?
Continuous phase and initial phase.
Yes. CP is a continuous phase and IP is an intensive phase. Intensive, not initial. Okay, intensive phase. So this is what we studied, discussed. Now that means you people didn't understood anything yesterday. Huh? We discussed now how the regimen is designed for intensive phase and continuous phase.
Yes, sir.
Okay, go back and revise that. Okay, so for intensive phase 2 we had told for the continuous phase 4 months. You remember, and the drugs are SRJD. What is SRJD? Mahesh.
Hello, sir.
Yes. Do you know what is SRJD? DT.
Rifampin,
It's
isoniazid.
isoniazid. R is rifampicin. Z is nitrosamide. E is rifampicin. Am I clear? Am I clear? Isoniazid, rifampicin. pyrazinamide, and ethambutol. Am I clear?
Yes, sir.
Yes, sir.
Okay. So we can remember by RIPE. This is the mnemonic to remember. And if there is streptomycin, also we call RIPES, RIPES. Okay, that we also can remember. And SRZ is abbreviation or acronym for that. So previously we used to do 3 times per week. Okay, both the thing. But now it's a daily regimen. Okay, you can see 7 days, and that's what we also discussed yesterday. That's you can give a daily. So this is a big change that happened in 2017 actually. You have to give every dose, every day, okay, for the new cases, okay. And if you remember yesterday we discussed how you treat the treatment for the new cases and treatment for the previously treated cases is different in cases when it comes to tuberculosis. So new case, just we have the change happened is daily. So main change that happened in this 2017 is daily doses regimen, okay, instead of twice or thrice a week. Then previously treated patient, this was the regimen. Okay, 2 months, 2 months with streptomycin, 1 month without streptomycin, and thrice weekly. Then 5 months SRE, that is isoniazid, rifampicin, ethambutol, without pyrazinamide, for like thrice weekly. But here you can see in previously treated, the drugs remain same, but what change happened is daily. Okay, they have to take it daily. Now, previously, what used to happen is the patient used to get a box, okay, and in that they had multi blisters and combi packs, and from there they used to take one drug from this, one drug from this, one drug from this, okay, and then they used to take. But now, from 2017, the fixed dose combination pack has come, FTC, okay, so it has become a lot easier for a patient. I will show you the picture of this on the coming slide. So I hope let me again recap you what is new cases and what is previously treated. When I say new cases, what do I mean? And when I say previously treated, what do I mean? New cases, when I tell this is the same thing that has been discussed yesterday, but I'm just recapping for you people. That new cases are like which you confirm by microbiologically for the first time. Okay, that's a new case, and then if not microbiologically, you can also clinically diagnose by telling it could be probable TB, and then you treat it. Okay, so that's a new cases. Okay, but what's previously treated cases is like you had treated, as the name says, you had treated the patient previously. So probably now it is a recurrent TB. Okay, or probably because probably this could be the treatment after failure. Okay, after once the first treatment had got failed and now you are treating again, or patient lost to follow patient, you had given but patient didn't get back for the next course, and then any previously treated patient. So that's a very clear meaning of what is new case and what is previously treated patient. Okay. And this is the FDC that is coming now. Okay, it's very, like you can see in one strip there is like 4 FDC. Okay, 4 drug is combined here in one tablet. Okay, so you have here rifampicin 150, isoniazid 75 milligram, pyrazinamide 4 milligram, 400 milligram, and ethambutol 275 milligram. So in one tablet you are getting 4 tablets. Okay, in one tablet formulation you are getting 4 drugs. So that's a change, and it's really nice change. It's really very productive, and like this change really enhance the compliance. Okay, patient no need to get confused with many drugs and those boxes. Okay, we have 3 FDC also, which contains 3 drugs. As you saw in the treatment, sometimes the patient needs only 3 drugs, not 4 drugs. Okay, so if 3 drugs, then we have this combination of same without pyrazinamide here. Okay, am I audible? Am I audible?
Yes, sir.
I hope it's clear. Okay, so now apart from SREZ, we also saw that some patients need S, okay, streptomycin, which is a injectable drugs. So the dose is 15 milligram per kg. Maximum daily dose is 1000 milligram. Patients who are above 40 years may not tolerate, okay, and you have to lower the dose to around like you should not go more than 750 milligram. You know the reason, because these are having toxicity, mostly nephrotoxic in the elderly patient. Okay. Similarly, the patient weight is less than 50 kg. you should consider bringing the dose down to around 50 to um, 500 to 750 milligram. Okay. So this is also a big change actually. Now the drug has to be given as per the weight. Okay. So it's not like okay age or any other parameter. It should be based on weight actually. So because if you are not dosing based on weight, probably the patient is not getting the enough drug, and again the chances of resistance and treatment failure arises. And probably this is the reason why probably this could be the reason why India has still this much disease burden of TB. Because maybe because of improper dosing to the patient, maybe the patient didn't receive the proper dose, and then the treatment failed. Then complaints happen. So the dosing should be on weight. You can see here the first column gives you about the age gap, is duration, sorry, is calibration. So for example here, and these are the this number in second column and third column, you are seeing the number of tablets. Okay, in first column is for intensive phase, second column is for continuation phase. Okay, and this is for injection, third column is for streptomycin injection. So as and we saw this 75 milligram, 150 milligram, 400 milligrams, 275 milligram SRZ and SRE in the blister. Okay, in the FTC we saw that. So here, how many tablets you should take? You know, one tablet contain all this, another tablet contain all this. So if the patient is between the age of 25 to 39 kg, then sorry, if the patient body weight is around 25 to 39 kg, then he should take two tablets, okay, two FTC. If the weight is between 40 to 54 kg, the patient should take three tablets. If the patient is 55 to 69 kg, he should take four tablets. Okay. If the patient is greater than 70 kg, then he should take greater than or equal to 70 kg, he should take five tablets. Okay, of SRZD. In the continuation phase, again it goes like this, and in intensive phase, streptomycin dose remains like this. And according to new regimen now, there is no extension of intensive phase. Okay. Previously, as I told, at the end they used to do the culture and look at the look at the report, and based on that they used to decide whether they should increase them, where they should increase the intensive phase or not. But now the new regimen advocate that you should not increase the intensive phase. Then sputum for AFB was being repeated initially in the intensive phase. Now the sputum AFB. What is AFB? Krishna?
I don't remember.
Follow me.
I don't know, sir.
Acid fast bacilli. Okay, acid fast bacilli. The sputum for acid fast bacilli. You know the mycobacterium is acid fast bacilli, right? So sputum for
Yes,
this
sir.
acid fast bacilli was being done at the end of IP, and that is intensive phase and continuous phase. Previously, it was done like 2 months, 4 months, 6 months. Okay, and for intensive phase. For continuation phase, it was done like 3 months, 5 months, 8 months, and they used to see how is the response. But now it says at the end of the treatment, culture should be done for all the patients. Okay, a monthly clinical follow-up is recommended, and then long-term follow-up at 6, 12, 18, and 24 months. And continuous phase may be extended by 12 to 24 weeks. Okay, 12 to 24 weeks in certain TB cases, like we have like bone TB, then CNS TB, disseminate TB, which is like complicated form of TB. If so is the case, then the continuation phase can be extended by 12 to 24 weeks. Okay, but extension beyond 12 weeks requires opinion of the expert. Okay? Without that, it's difficult to take that. So this is again summary of the difference that we found. New guideline has come with a daily regimen. Previously we had intermittent regimen, and a new guideline ethambutol in continuous phase of both category 1 and category 2 regimen, but ethambutol in continuous phase of category 2 regimen only in the previous guideline. Okay, in the previous guideline there was no fixed dose combination. They had limited weight band, but now you have a fixed dose combination as per the weight band. In the previous guideline, there was extension of intensive phase for 1 month if the sputum was positive at the end of IP. Okay, but now there is no need of extension of IP. In the previous guideline there was a follow-up laboratory only, but now in the follow-up you have clinical investigation and laboratory also. So in the previous guideline there was no long-term follow-up, but now they have to we need to follow up the long-term. We need to follow up the patient for long-term, up to around 2 years also. Okay, so this is how you treat the new cases in adults. We already saw this. Okay, this table gives simply the calculation of intensive phase, how many you need, and on continuous phase, how many. For example, if the patient is, let's say, 30 to 39 kg, and you know if the patient body weight is 30 to 39 kg, then you have to take 2 SREZ tablet. So total number of tablets requiring will be 114, and based on that it is simply calculate like how many times are in one strip. Based on that they calculate how many strip is required, and then how many strip per month is required. Okay, so that's a like calculation of number of strip and strip per month for intensive phase and continuation phase also. So retreatment case, that means previously treated case. So here comes the diagram remains, the table remains same apart from introduction of this injection streptomycin here. So streptomycin daily for 2 months. So that's 56 around 56 days. Okay, and here in the last column number of streptomycin injections calculated. So this is again a recommended daily doses of essential first-line antitubercular drug for all the drugs. Okay, what is the daily daily doses based on body weight? Again, you can see how many milligram per kg body weight. Isoniazid in adults 5 mg per kg. The range is around 4 to 6 mg per kg. That is around 5 mg per kg. In pediatric, it's 10 mg per kg. In rifampicin, it's 10 mg per kg. For pediatrics, 15 mg per kg. Streptomycin for adults 15 mg per kg. Pediatrics 15 mg per kg. Methambutol 15 mg per kg in adults, 20 mg per kg in pediatrics. Pyrazinamide 25 mg per kg in adults and 35 mg per kg in pediatrics. So these are some of the newer drugs, bedaquiline, delaminate we're talking. So this when this drug came, it has completely new kind of mechanism that we didn't see for any other older drug. It acts by blocking the enzyme inside the mycobacterium tuberculosis. That enzyme is ATP synthesis. So it is the mechanism is simple. It inhibits the energy production in the mycobacterium and kills the bacteria. So, but it is never used alone. Okay, it is used in the combination with other TB to treat pulmonary TB in adults when they have MDR TB. It should not be used in the treatment of latent TB infection. So, if the patient have latent TB infection, it should not be used. It should not be used if the patient is allergic to any kind of antitubercular drug, and if the patient have extrapulmonary tuberculosis, it should not be used. And if of course if the infection is by any kind of non-tubercular mycobacterium, it should not be. Recommended doses for bedaquiline is 400 milligram once a day for 14 days, and after that 200 milligram 3 times a day and 3 times a week for next 22 weeks. Okay, the common side effects are like headache, joint pain, increase in liver enzyme, feeling some kind of sick. Then basic criteria to start is like if the patient should be greater than 18 years. This is very important. Bedaquiline we don't use in pediatric patient. Okay, the patient should be more than 18 years. The patient should not be pregnant. Okay, and patient should not be willing to practice and patient should be willing to practice contraception. Okay, if the patient is not willing to practice contraception, again it's tricky to use this drug. And that till how much ever time the patient is on this drug, that much of time. And bedaquiline is also found to have major cardiac issue. Okay, heart issue. So if the patient have some arrhythmia or QT prolongation, all those kind of things, we recommend not to use this. Then mandatory period for 2 weeks of treatment is if initiated. Okay, if you have a starting patient on bedaquiline, you have to treat the patient for at least 2 weeks, for at least 14 days. You cannot stop patient without treating it in this. Okay, Coming to this new drug, dilamanid, second new drug, dilamanid is an active substance it is active substance in a new tuberculosis drug treatment. Formerly, this was its name. Okay, this is how it was coded. It's a it's the first in a class of tuberculosis called nitroimidazoles. Okay, this comes under chemical classification of nitroimidazoles. So this is the first new class of tuberculosis. We didn't have any such class in anti-tubercular drug. Given to adults with TB that is affecting lungs and which are MDR TB. So basically, this bedaquiline and dilamanid came for the MDR TB, okay, not for the general kind of TB. So the dose is 50 milligrams twice a day with food for 6 months, okay. And of course, like bedaquiline, dilamanid also have side effect of QT prolongation, like heart issue, and kind of arrhythmia the patient have, and then anxiety, dizziness, and nausea and vomiting. This is the drug which recently came, I think 6 months back, Ritonavir. It is another nitroimidazole, which is the dilamanid class. This is potentially used for the treatment of both drug-sensitive and drug-resistant TB. Okay, so unlike bedaquiline and dilamanid, which is only used for the resistant TB, MDR TB, it has shown activity against both latent and active TB. Okay, so you can use Ritonavir for both latent and active TB. And the good things about Ritonavir is I think you can use this in pediatric population as well, unlike bedaquiline and dilamanid. Okay, so these are some of the advantages of DOTS therapy. You know already what and all were the problem. So those problems are being overcome by DOTS. Okay, so this is in brief about the general, like what they updated, okay, from the older treatment, older guideline. So if you have understood the older guideline, um, I'm not making compulsory for you to go to the older guideline, but you'll have better understanding if you read the older guideline first and then the newer guideline. Even if you directly read newer guideline, no issue with that. You can go with this. Um, but once you go back a little bit in the history also, it will make your understanding more concrete, and that like why such changes has brought in the treatment of tuberculosis. And you'll better understand the problem, the burden associated with tuberculosis in the country, and even you will have better understand the manipulation and like how they are modifying the dosage regimen each day, okay, each years as the years are passing. So if you have any queries, any question related to this, you can ask me. Otherwise, with this, I complete the tuberculosis chapter. Anybody?
Sir,
Yes.
so I have a question. I just wanted to know, as we are talking about the new cases and previous cases.
Yes.
So the medication, some medications of the TB may cause other complications like psychosis or other hepatotoxicity. So where it will be included?
I didn't get you. What I discussed is we have a newly diagnosed TB patient, and we have
Yeah.
previously treated patient. So newly diagnosed patient means I told those who you are identifying based on microbiological. When you did a culture and you got to know that there is a mycobacterium tuberculosis, or you clinically suspected that the patient might be suffering from tuberculosis, and you put a probable diagnosis of TB and you start the regimen. So that's a new cases I told. And the previously treated patient can be like treatment failure, loss to follow up, like in any way you have treated the patient previously. That why it is categorized in this way is just to give us idea that if the patient is previously treated, we need to treat aggressively, as you saw in the regimen, aggressively and seriously, because there is chances that the patient might have got resistance, and so the regimen is different. So what is your question actually? I think your question is related to previously treated, something like that.
Mm, yes, I mean that medications of that TB causes some complications
Yes.
like isoniazid induces psychosis and all.
Okay.
So where it will be included?
where it will be included means you're asking whether new
Yeah,
cases are
new
previously treated.
cases.
Of
Yeah,
course, if you have
yeah.
treated, the definition are very clear. If you have treated the patients, then of course it will go in the previously treated. As you see here, let me go to that slide. As you see here, how we define new cases and previously treated cases. You see here, or any other kind of previously treated patient, maybe recurrent TB because, or maybe because of treatment failure. Yeah, we have when it comes to side effect, we have many side effects of anti-tubercular drug, and we have the way to tackle it. For example, you told the problem related to isoniazid. For that, we give another drug, which is a kind of antidote. Can you name that? Paradoxine. Okay. Vitamin B6. Okay, whenever the patient is an isoniazid, we have to give vitamin B6. Okay, so so that is one strategy. Other strategy is, as I told, to look which drug is causing and then stop the suspected culprit one by one and to figure out what that drug is, and then of course the supportive treatment. Okay, many times this what is that, Lola, alorthinin, alaspergillus. You might have seen in the word that one sachet. It comes in one sachet. Hepamerge. Have you heard of that? Hepamerge.
Yes, sir.
Okay. So there are many supplementary treatment that we on the way we manage the side effect in the patient being treated with anti-tubercular drug.
Okay.
Anybody have any question? Anybody have any questions? No questions? Shall we wind up?
Yes, sir.